Hello, my name is Vatsal Bajpai. I'm a second-year cardiology fellow here at Indiana University School of Medicine, the Kennedy Institute of Cardiology, and I would like to present this interesting case that we came across a few months ago here at this point. It's entitled "The Painful Lift." Um, and the first thing I like to say is I nor any of my colleagues or are attending have any relevant relationships or any disclosures at this point. So we'll start off with the patient history. The patient is a 23-year-old gentleman who is uh, basically does Olympic weightlifts in his spare time. He has no prior medical history apart from asthma, and he actually presented with a kind of sharp chest pain and pressure-like at times as well, left-sided, non-radiating. Um, It started after he was doing one of his lifts. He was actually doing a clean and jerk at that point, and the weights that he'd been lifting were upwards of 200 to about 300 pounds. And he had some nausea associated with this as well, but no vomiting and some lightheadedness. And then he presented to the ED about 4 hours after the onset of the pain had been going, had really no remitting factors until he got to the ED. He denied any illicit drug use, denied any kind of anabolic steroid use as well, and he had no family history of any early coronary disease. So on initial evaluation, he appeared very uncomfortable when I first saw him. We did get an EKG initially. You can see that here on the right, and sinus rhythm just had diffuse anterolateral ST elevation. We got it. Troponin was obtained as well when he first came into the ED, and it was elevated at 2.3 nanograms per milliliter, much higher than our reference range, which is seen there. I did a bedside ultrasound on him, and it showed apical hypokinesis as well. And in the midst of all this, his COVID-19 rapid PCR test came back as positive. So, given kind of this constellation of symptoms and findings, we decided to activate the cath lab and take him for an emergent coronary angiography. A little background here: this was pretty early on in the pandemic itself, and there were some institutions that were doing thrombolytics for these patients. However, at this institution, we did not have a protocol for thrombolytics for COVID-19 patients, and so we took him to emergently for angiography. And I'll show you the images here. I have some representative angiographic images here. You can see basically his LAD is thumbed off here in the areocranial view, and then again, aleocrania, you can see LAD stemmed off again. However, there's no atherosclerotic disease anywhere. His circumflex system looks fine, and as similarly to his right coronary artery, there was no atherosclerotic disease there. So, given these findings, there was concern for distal left main to proximal LAD mural thrombus, and so we decided to proceed with intervention at this point. And the LAD lesion was actually easily traversed with the run-through coronary wire. There were serial inflations with the 2x12 millimeter non-compliant balloon, and several passes of the export advanced aspiration catheter were unable to restore flow. So at this point, we decided to use the mechanical power aspiration with the Indigo system, CAT-RX, or Penumbra, as it's colloquially known. That was actually successful in restoring flow with significant thrombus removal, and you'll see this in the next slide. He did, we did the apical LAD, which did show evidence of reduced flow, as you'll see on the next slide. This was treated with multiple intracoronary injections of nitroglycerin, adenosine, and verapamil. It was really minimal improvement. There was no coronary stent placed, as there was no evidence of underlying lesion after the thrombectomy was done. So here you can see the aspirated thrombus on the left, and on the right, I'll show you a representative sample of the post-PCI angiogram. And you can see there's restoration of TEMI2 flow where there was previously stumping off the LAD. So he had a pretty uncomplicated hospital course, and he was actually discharged on hospital day 3. However, post thrombectomy, he was continued on eptifibatide intravenously for about 18 hours. He had a full transthoracic echocardiogram which revealed a normal left ventricular ejection fraction with apical wall motion abnormality, similar to what we'd done in the emergency department. He had a pretty extensive hypercoagulable workup done. Actually, he followed up with hematology as well. And you can see we tested him for factor V Leiden and antiphospholipid syndrome and prothrombin, and all this was prothrombin mutation, and all this was negative. After this, at the end of this hospitalization, he was discharged on aspirin 80 milligrams, the Cagrelor 90 milligrams twice a day, and the Apixaban 5 milligrams twice a day. And the Apixaban actually was stopped after 1 month. In the interim, he actually went back to lifting. We had advised him not to go back to his previous levels of activity, given that there was a paucity of data on kind of how to manage athletes post ACS with COVID. However, we had we have some data with other viral illnesses and acute coronary syndrome. So we advised him to kind of basically not go back to his weightlifting until he saw us in clinic, which was about 6 to 8 weeks after we saw him in the hospital. However, he went back to lifting and actually returned to the hospital instead of coming to the clinic about 3 months after his initial presentation with chest pain again and troponin elevation to 0.27 nanograms per milliliter. His ECG on this presentation had resolution of the prior SC changes, but did have a new intraventricular conduction deficit, which was consistent with prior injury. And given his history, he underwent repeat cardiac catheterization. And I'll show a representative image of that on the next slide. However, it showed complete resolution of the coronary thrombus. And so again, just a representative angiogram here. And you can see the LAD actually has TIMI3 flow, and it's actually much improved from our final post-PCI shot that I showed on the prior slide. So we thought this was a pretty interesting presentation. It led to the question of what exactly is the proposed mechanism behind acute coronary syndrome and COVID-19 in particular. And so the options here are: is it due to direct endothelial disruption, or is it due to a cytokine storm, or is it due to activated macrophages leading to plaque rupture and hypercoagulability, or is it indeed a combination of all of the above? So it is, in fact, D, all of the above. Early on in the pandemic, there have been a lot of studies coming out, histologic studies that show that there's been direct viral infection of the endothelial cells and diffuse inflammation. And as we know this is well known that activated macrophages do secrete collagenases that degrade collagen, which is a major constituent of the fibrous cap on atherosclerotic plaques, which can lead to plaque rupture. Macrophages also secrete tissue factor, which is a known potent procoagulant. And finally, we all know cytokine storm leads to systemic inflammation, which is in and of itself a prothrombotic state. So just to finish up here with conclusions and learning points, really what this case highlights is the need to have a high index of suspicion for acute thrombotic occlusion in patients with COVID-19 and ECG changes, regardless of kind of their age or any kind of viral prodrome, of which this patient had none. And this is particularly important because we now know that COVID-19 is a hypercoagulable state, and there are multiple proposed mechanisms for this, and plaque disruption as well with the coronavirus. So there have been multiple case studies going back from Italy at the beginning of the pandemic, China, and also New York, which showed acute thrombotic occlusions without other significant atherosclerotic disease, which is seen in COVID-19. And this is important finally because the best management of these patients is a pretty nebulous concept at this point. There are no set guidelines. However, the people with intercoronary thrombosis related to viral syndrome usually encompasses a wide variety of treatment modalities, and that can be seen in this case with aspiration thrombectomy, therapeutic anticoagulation, and dual antiplatelet therapy.